I will begin to introduce this session, which is so important, and that is the healthcare reform. We all know that President Obama had an improvement in our health system in the United States as a top objective when he took office. We also know that passage of the Affordable Care Act, which happened in 2010, was enormously contentious. The objectives of this act are to get more people to have insurance so that people in the United States are as close as possible to fully insured for their health. Hopefully, this would lead to lowering the risk for everyone. Everyone would be covered. In long term, the quality would improve across the nation, and the costs of that improved quality would drop over time. That was the objective. The program had a stutter start at the end of 2013, and during the early months thus far of 2014, by May of 2014, 20 million additional people were covered with insurance through these insurance exchanges. There are subsidies available and mandates. The mandates for individuals were said to be constitutionally okay after a fight, but there are still mandates for small businesses, which are still in problem area. And so there's great progress, and there's every reason to believe that the biopharmaceutical industry is going to have all kinds of reactions. Should be very good in that more people will be insured, therefore there are more people able to pay for drugs. That should be on the positive side. Are there negative things? We're going to hear today, and we have a panel which is unbelievably qualified to handle this subject because we have people who are involved in the birth of a person who was involved in the birth of the ACA, the Affordable Care Act, a person who has been involved in the philosophy of the economics and the studies that are largely behind it and are looking to see what the outcomes are going to be and what the outcomes are going to cost. And we have people from the industry who are obviously going to tell us what impact is the Affordable Care Act going to have on the biotechnology or the pharmaceutical industry. And we have these experts with us. And what I will ask now is that I'm going to introduce each of the four panelists in turn, ask them to speak for 8, 10 minutes, whatever they like, the initial statements, but no questions at the end of their talk, because I would like to go through all four before we open to questions. I will lead with some questions, or you can lead with questions. But the field will be wide open, and I will start with Dr. Mark McClellan, who will be this first kickoff speaker. Mark has a remarkable background and accomplishments at this very young age, I would say. He was an MD. He's a physician from Harvard, from the Harvard MIT program. He then took a Ph.D. almost simultaneously in economics at Harvard, and then has an additional degree in public administration at the Kennedy School. He has been studying healthcare outcomes and costs for many years. He is a true professional economist, looking at it without being concerned about industry versus public versus whatever, insurance. Most remarkably, he has been at one time in his career head of the FDA. And so he's hands-on with regulatory problems of the industry and facilitating drug availability in the United States. He's also run the Medicare and Medicaid program in the United States. So he's been right in the middle of it. But currently, he's at the Brookings Institute, where he has been for a number of years. And his target is understanding the economics of the best of healthcare and what the effect on people is, and what is the effect on the economy of the United States. So I would ask Mark to give us his first statement. Mark.
Roy, thanks for that introduction. I'd like to thank you and the Galien Forum for the opportunity to be here with you all and to follow such interesting panels on truly remarkable innovation in process in biomedicine. I do want to link that and start out this discussion by connecting it to what's going on in healthcare reform. And as Roy mentioned, the emphasis is on the implementation of the Affordable Care Act. But what I want to emphasize is that while the coverage expansions are well underway, are going to continue to expand out further over the next few years, healthcare reform is still really in a important stage of development, where we're really seeing some transformations occurring, not only in how medical technologies are developed, but in how healthcare is delivered. The outcome of all that, I think, is not clear. Hopefully it'll be a good topic for discussion with this panel, but it is going to lead to some big changes in the healthcare industry, and hopefully some changes through greater, more efficient innovation in bringing some of the breakthroughs like immunotechnology and better treatment for heart disease to patients faster. We've got a lot of pressures that are leading to this. On the one hand, are rising healthcare costs, even with the slowdown in healthcare spending growth that's been highlighted in the last few years. The outlook for the federal budget and state budgets, because of demographics and shifts to public programs, is still very, very challenging. The federal outlook accounts for essentially all of the increase in federal deficits projected over the course of the baby boom, a little bit due to Social Security. But I think an even more important factor in driving further changes in the way that healthcare plans and healthcare coverage and healthcare delivery will work are the changes that are happening in the biomedical sciences, where we are clearly moving towards more personalized therapies, not drugs that are going to be used individually on very large patient populations, but as you've heard about already this morning, combinations of treatments that are increasingly well tailored to an understanding of the biology and preferences of individual patients who have increasingly diverse needs for therapy. And that suggests that the kinds of ways that we paid for healthcare and the kinds of ways that healthcare financing has worked are going to change. We're starting to see a lot of that now with movements away from paying on a fee-for-service basis, where the prices just keep getting squeezed down, like in the Medicare physician payment system and in some other parts of the Affordable Care Act, and instead a shift towards payments that are more at the person level or at the overall level of treatment for a health problem, and the payments are tied to some accountability for actually getting to better results and lower overall costs for the patients. I think this is important both for the biomedical technologies, the costly breakthroughs that are coming along, and for the other opportunities for innovation in health.
and have an improvement in the rate of innovation from the amount of money that was being spent by the NIH. Of course, that amount of money hasn't gone up over the years, so it's shrinking anyway. But after a number of years at NIH, Elias switched, and there was an interim period, but he then switched to become a global head of R&D at Sanofi, where he has been for a number of years, about 3. And there he has looked to oversee the global aspects of a company that had been put together in pieces over the years and needed a good deal of bringing together and prioritization of what was going on. So Elias has a background, academia, startup companies, a big company, R&D, global R&D organization, and director of the NIH, where he was on top of a $30 billion research budget. So he certainly has ideas about healthcare reform. Elias.
Thank you, Roy. First of all, thank you for inviting me. I'm pleased to be on this panel, actually replacing Chris Viehbacher, who couldn't be here for reasons that probably the public knows, and he tried to manage a little scuffle with his board in Paris, which I think he did well. And so I'm really here, and what I will try to do is really bring my perspective from having been at Johns Hopkins, and I was executive vice dean there when I ran basically the School of Medicine and looked at healthcare from the point of view of an academic health system, and then as the head of the NIH, where I looked at research, biomedical research, both in the US and worldwide. And after a little interlude at the Gates Foundation, came to this job where I'm looking at it now from the industry side. And I think that, first of all, let me thank you for letting me speak before Zeke. Because I know Zeke. Zeke was at the NIH, and I tell you, if you let Zeke talk, he will say everything there is to say. And my problem in life has been that my name starts with Z, so I always end up being last and really not having anything new to say. So thank you, but thank you for having Zeke, who starts with Z as well, be the last one. So with that, let me just say this. I think the Healthcare Reform Act of the US is a first step. It's a good step, but it's a first step. It's not the last step. I think if you really step back and look at the macro forces that are really affecting the need for reform, not just in the US, but worldwide, is a fundamental tectonic shift that is occurring. And the tectonic plates that are under tension are the tectonic shifts that are required in the budgets, as Mark was mentioning, in patient care, in the disease landscape, the providers, the industry, and so on. And everything is under tension right now. Whether you go in Europe or Asia or the US. And so we have to realize that I think this first step, in my view, has opened up the possibility for the system to evolve. The system was locked, and I think this is what we should look at in terms of the significance of what we're seeing. So obviously, it's evolving right now. I don't think everybody understands the direct and indirect effects of the reform, nor do we understand the intended or unintended consequences of the reform. But the thing that is really important to me is that this is an opportunity for correcting pernicious incentives that have percolated within the system since the 60s in the US. I think it's clear that the system as designed cannot last. And it was designed for reasons that all of us know, political expediency, the fact that healthcare is no longer considered a privilege. Healthcare is considered a human right. And it wasn't the case 100 years ago. If you had the money, you could go to the doctor. If you didn't, tough luck. Today, this isn't the case. I think all societies, all modern societies, want to consider healthcare as a human right that the state has to provide, and provide within accessibility criteria that are humanly reasonable. So we need to understand this major change and understand that, in my view, what this reform permits is the ability for us to learn new ways. And I think you've heard some examples already of saying, well, we should not pay for inputs, like the drug or the intervention, the operation. We should pay for outcomes. That's easy to say. but it's not so easy to organize. The same thing happened in terms of public health. When you look at the landscape of disease, it's gone from acute diseases of the 40s and the 50s to chronic diseases that affect ones over their lifetime. And the same system is trying to tackle a heterogeneity that is unbelievably complex and not possible to tackle with the exact same system based on major infrastructure such as hospitals, major specialty and primary care systems which themselves are not incented to really manage chronic diseases. I can tell you, for example, that I, as a dean, had to equilibrate between the departments that provided technologies, procedures, as opposed to the department that provided cognitive services. Pediatricians are notorious for being underpaid in the system, yet they are key to the prevention over the long run of rising healthcare issues. So I think the landscape of disease has changed. The heterogeneity of the system is such that we cannot have a one-size-fits-all. We need a system that learns. We need a system that has enough leeway for new models of healthcare to be tested, to be tried. It's obvious that the landscape of medicine is changing. So when I started my job at the NIH, Roy mentioned this roadmap. The number one thing we heard from all the constituencies was we needed a shift in medicine, going from reactive, where we waited for the patients to be sick before they came in contact with the healthcare system, to a preemptive system, where the patient actually would not be sick. Because we know Alzheimer's disease starts 20 years before the clinical symptoms. We know that diabetes is predetermined 20 years before we have a glycemic dysregulation. So how do we do this? And so we came up with a concept that medicine had to really follow 4 pillars. It had to be more predictive. We had to do the science, fund the science that will tell us what is the risk and how to predict exactly what will happen in the evolution of a chronic disease. This notion that diabetes is one disease, for example, is something that's a little bit naive. What it is the day one, or MS, for example, what MS is on its first day may not be what it is on its 5th year, and is not what it is in its 15th year. And so we need to really do a lot of research. And my frustration was that we didn't have enough investments in basic science to understand not just biology, but human disease biology. So I think the healthcare reform is forcing us to some extent, to change the way we're managing 75% of our costs, which is chronic diseases. So if there's one thing that needs to be focused on in the healthcare reform, is how do we manage this humongous cost that is increasing very fast because of aging, and what can we do as an industry, as providers, and so on to do it. Now, in terms of changing from a reactive to a predictive and preemptive medicine, you will need a change in social constructs. You will need a change in the way healthcare is considered in society. And for example, we did studies on what we call the built environment. Do you know that if we build every building in the US with elevators that will only be available from the 3rd floor onward? In other words, there will be few elevators from the ground floor to the 3rd floor, just for individuals who couldn't, walk up the stairs. You'd reduce obesity by 25%. Just that. And those things need to be allowed. And it's really amazing that we're not able to have a system that allows experimentation of this kind to, in fact, prove that the value is there. Now, let me make a point, since now I'm from the industry side, let me make a point that is often forgotten, and that is that the innovation that is needed is multidimensional. It's not going to be a drug, a magic drug. I mean, you've heard about single drugs that treated single diseases and had cures. Well, that happens in infectious diseases. But it's not going to happen in chronic complex diseases. I don't think there will be a magic bullet approach. So we need to really figure out how the solutions that are deployed for the patients are really maximized in terms of their value. And I think George said it. Every R&D organization I know now in the industry is no longer focused on me toos. You don't survive with that. Payers are telling you we're not paying unless there is value demonstrated. So I think the industry is shifting already, listening to